my fear.
So good morning once again to everybody. My name is Dr. Ajilabi Adedotun. You're all welcome to today's discussion. We're having a webinar where we give awareness, we create awareness about hypertension and its management. So you're all very welcome today. Happy Workers' Day, happy new month. It's a very beautiful new month. I hope that we receive all that we are hoping for this new month. Before we start the program today, I would like someone to volunteer for an opening prayer. Please, can someone volunteer to give an opening prayer before we introduce the speaker?
Shall we pray?
Yes.
In Jesus' name. Our Lord and our Father, we thank you for the gift of life. We thank you for a beautiful day called May Day. We thank you for strength and grace and stability. We thank you for provision. We thank you for good health and a sound mind. We thank you for the ailing that may be on this call or may not. We thank you for your sons and daughters whom you use to put this together as to enlighten the public. Father, we give you all the praise. Receive our thanks in Jesus' name. Lord, we pray that as we go into this session, as you have helped us in times past, you will offer unto us your help. We pray that our finances will not be for ill health in the name of Jesus. We thank you because we know that you will grant the speaker utterance today, and we pray for stable network across boards, that your children may learn all that we need them to learn, and wisdom may profit them in Jesus' name. We give you all the praise, Lord. In Jesus' mighty name we have prayed. Amen.
Amen. Thank you very much, Mrs. Adekbojo, for the opening prayer. I'll move straight on to introduce the speaker. Our speaker today is Dr. Eniola Afolabi Obe. She's a fellow of the West African College of Physicians, and she's also an international board certified lifestyle medicine physician. She is currently employed as a consultant in the Family Medicine Department of Lagos State University Teaching Hospital, Ikeja. Dr. Afolabi Obe is one of the team of physicians that run the lifestyle medicine and wellness clinic of the hospital. She has special interest in lifestyle prevention and management of chronic medical diseases such as hypertension, diabetes, arthritis, overweight or obesity, as well as wellness and health counseling. She's a member of the Society of Family Physicians of Nigeria, SOFPON, and the Society of Lifestyle Medicine of Nigeria, SOLONG. So Dr. Afolabi Obe is well versed in treating and discussing about hypertension and creating awareness. And I crave your indulgence to be attentive and to listen to all that would benefit today and to jot down your questions. If you have questions, please write them down so that at the end of this session, we'll be able to take the questions and have an interactive time. Thank you very much. Dr. Falabi Obega, welcome to share your slides. and then start your presentation.
Thank you once again, Dr. Ajelabi, and good morning to everyone on the call this morning. Please confirm that I'm audible.
Yes, ma, you are audible.
Thank you so much. I'll continue to share my. Can you see my slides, please?
It's showing the end of the slide. We are yet to see the beginning of the slide, so you can try to go back such that we can. Very good. Yes, ma.
All right.
Yes, we can see the beginning.
Okay. Thank you so much. Yeah. Good morning again. I'll introduce myself again. After the And I must say thank you for the invitation to be able to enlighten us again on such a topical issue this morning, which is metabolic syndrome. So I know these are esteemed set of people that are here. So thank you for willing to listen to this presentation. So I know that there are a mix of there's a mix in the audience. So I'll try as much as I can to make it easy to understand for us and easily comprehensible also. Thank you once again. So, metabolic syndrome epidemic, what you need to know. So that's the topic this morning. So I'll proceed by sorry. So at the end of this presentation, please confirm these slides are clear on the other end.
Yes, we can see your slides clearly,
All
ma.
right, thank you. Yeah. So the learning targets, so that what are the things we are looking out to learn from this short discussion we engaged in this morning? The first would be to understand what metabolic syndrome is, meaning exactly, and how does it come in play? What role does it play in the connection between what role does this metabolic syndrome play in disease progression for cardiovascular diseases and type 2 diabetes? And thirdly, we would also want to highlight the common risk factors that are commonly implicated and we want to pay attention to, and then to cap it up with ways, evidence-based measures we could use for control of this syndrome. And I'll follow this outline. Yeah. Okay. So to begin with, metabolic syndrome. It has a lot of names. Yes, I know we all know metabolic syndrome, but besides it being referred to as metabolic syndrome, it also comes to mind as syndrome X, insulin resistance syndrome, cardiometabolic syndrome, this metabolic syndrome. And what do all these terms refer to? It just means a constellation of a lot of metabolic abnormalities that comes together in just one patient. There are these metabolic abnormalities as well as other cardiovascular risk that you find in just one patient. So it's not just one entity. It's more than just one entity in a single patient. And it's a disease with multiple risk factors, with a baseline or the root cause usually starting with insulin resistance, with following up with abnormal adipose tissue and abnormal adipose deposition, and other risk factors that come in play includes the coronary heart disease, diabetes mellitus, type 2 diabetes mellitus, fatty liver disease, and other cancers have also been linked to it. So like I mentioned earlier, it's a lot of the initial terminologies I mentioned about it being syndrome X and the likes have come to play over a period of time. So the definitions have changed over a period of time. And however, though it has changed, each of these definitions have retained their features. And it's important to state also that despite the fact that it's being referred to as a syndrome, it's important that we are able to recognize each of these pathologies, and in doing that, we are able to take decisive steps in coming to a diagnosis and managing the patient as appropriate. So, sorry. It's just a minute. So it's also referred to as the lifestyle syndrome, yeah, or the New World syndrome, because it's been found out that the root cause lies a whole lot in our lifestyle, the way we live, the way we do things, and that's the reason why you're having this terminology. And aside the other things that come in place, talk about the fact that different from, apart from the cardiovascular conditions associated with it, the metabolic, it could also come alongside renal abnormalities, inflammatory abnormalities in that patient. And even now, it's being said now that other things are being included, which includes fatty liver and as well as sleep apnea. It's important to note that a lot of times in primary care, most of the conditions that the patient comes in with are usually lifestyle related. And one of them is what we are discussing this morning. Like looking at this slide, 80%. So that means if 10 patients come to the clinic, 8 out of 10 will come with a condition that is lifestyle related. So if it is, then that means it's a whole lot lies on us for us able to make a lot of changes in the lifestyle in our lifestyle in order to be able to reduce the incidence or the prevalence of these conditions. However, it's also important to know that aside this, other conditions that are found commonly include dyslipidemia, just simply arthritis, type 2 diabetes, osteoporosis, and a few others also. So back to metabolic syndrome again. It's a clustering of central obesity, hypertension, dyslipidemia, insulin resistance, and glucose intolerance in the patient. So it states that it's with this happening, the patient has a risk. And that's why we are stating it. That's one of the reasons why we are raising this awareness. We're putting up people should know about it, that even though the patient comes in with these conditions, it may not be clear cut that the patient has developed them, but the patient stands a risk of developing the eventual condition or even worsens the prognosis of such conditions. So cardiovascular diseases, as we all know, is the leading cause of global death, is the leading cause of death globally. Looking at statistics, an annual, and as much as 31% of the total global deaths have been attributed to cardiovascular conditions. In the same vein also, type 2 diabetes is another common non-communicable disease, which is of public health concern, and is also really going up in terms of its strength. If you look at these statistics also, it states that approximately 10.5%, so that means 10.5% of the adult age group are presently living with diabetes mellitus, and some of them don't even know. So going forward, like I mentioned earlier, these conditions are usually related with each other. Over the years, over the period of time, we found out that cardiovascular diseases and impaired glucose control have a connection with each other. It's been noticed that this connection is usually in a positive direction and is usually in a continuous manner. So what it means that, for example, is for a patient whose HbA1c keeps increasing, it also means that the HbA1c is one of the indices we use in measuring or checking for glucose control or the fasting blood sugar and the likes, as you may say. For that kind of a patient, it means that for every increase the patient encounters, or for every change in the negative direction the patient has, he or she stands the risk of coming down with these conditions. And further studies have suggested that there's a vital link between these two. And it's very important that we understand what this link entails. So I'll move forward from here. I think these have all been mentioned earlier. So epidemiology. The prevalence of metabolic syndrome has been on the increase globally. So like, if it's not even just an epidemic, it's more like a pandemic because it's world over. It's not just affecting, it's affecting both developed countries, developing countries. So it's not just, it's not limited to a particular region. It's actually a global condition. So it's been categorized now as a pandemic as much as 25% of the world adult population. So that means that 1 in every 4 adults in the world has this condition. So it goes to tell us how important this topic is, and we also need to pay a lot of attention and make sure we're able to curtail it as much as we can. The other studies here shows that from a collection of data, it was found that as much as 35.3% of men and 33.3% of women in the United States have this. And besides that, it's also important to know that with increasing age, this condition becomes more prevalent. And women are more, women have a higher, the prevalence is higher in women, especially in Black women compared to the other races. So it doesn't leave, apart from the fact that adults have been affected, children are also not spared. So it's not just a restriction to a particular age group. You also have children now having rising prevalence of that also. And what that means is that for a child to begin to have a condition of such at an early age, it will definitely have an impact on the eventual quality of life the person tends to live as he or she grows older into adulthood. Studies have found that 3% of children, as much as 3% of children and 5% of adolescents globally have metabolic syndrome. And why is this happening? It's been attributed a whole lot to rising cases of physical inactivity now compared to what used to be the case. A lot of children, even adults, children and adults all the same, are less engaged in physical activity. A lot of times we are engaged in we have a sedentary lifestyle. Sometimes, for example, a child wakes up in the morning, has his or her breakfast, has little or no movement at all, moves to school and spends almost all the hours of the day in school in seated position, comes back home, possibly comes back home, lies down on the bed, comes back to eat again. And this keeps going on and on and on. Same for adults also. A lot of times you're right inside your car, you get to walk, you sit down, you hardly move around. Even when you are just a few steps or the movement is not like, in a way, it can still be referred to as a sedentary lifestyle. Other things implicated are consumption of unhealthy diets. What do you mean by an unhealthy diet? Unhealthy diets are diets that are high in calories. They are high in fat content. They are more calorie dense, but less nutrients. So what that means is that the nutrient the body requires is not actually there, but you are consuming more of those calories. And what you find that a whole lot in fatty foods. You refine sugars. You find them in a lot of trans fat, saturated fat, which we find a whole lot in most of the food or most of the items to consume. Most of our foods now are more processed compared to when they were really unprocessed. Obesity is also another reason why this has been found to be increasing in the younger age group. For developing countries, we can see that if you compare the prevalence in the developing countries and developed, we can see that the difference really wouldn't be much. You wouldn't say it's much. So that shows, that goes to tell us that we wouldn't say, oh, it's more of a condition we find in the developing countries. Now it's here with us, and we really need to pay close attention to that. And it's also important to know that the prevalence actually depends on the definition from which the definition that gives the metabolic syndrome. I'll still go on to that. Looking at the few literature reviews and all that I mentioned here, you can see that for Nigeria, according to these definitions, these various prevalences have been found ranging between 28.1% to 31.1%. They actually look close to each other, so it's not really far-fetched. And besides the fact that the prevalence is getting higher, we should also realize that it has a great impact on the healthcare cost. Because these conditions are rising, there's a tendency that the amount or the cost of healthcare definitely, especially because most of the patients around, even pay out of pocket, tends to be higher. Then indirectly affects both the direct and indirect healthcare costs in managing this condition. And it comes to a point at which this may not be sustainable. And the essence of instituting comprehensive preventive measures and strategies to bring it to a recline or a decline the global prevalence of metabolic syndrome is really important. So I'll go to a bit of history right now. It's not a new condition. Far away into the 1970s, the first recognition was when was termed the metabolic syndrome. Then was coined from the word then in 1920s. But later on, you can see that subsequently other people came in, the French physician, talking about the fact that noticed that the upper people with a larger upper body had increased risk of conditions such as diabetes, kidney stones, atherosclerosis. And thereafter was also noticed that people who consumed or who had a whole lot of who had their diets, who had a low calorie diet and low carbohydrate diet, it was found that in them they demonstrated an improvement in the control of the chronic conditions they were managing. Report was said to have been done in about 6 obese patients in which this was noticed, and this was also something that was noted then up until 1977, and when it was found out that the risk factor for the condition was atherosclerosis. Thereafter, going to 1988, I'll move on to that. Gerald Breven found out that a baseline or a root cause of this condition had to do with insulin resistance. It was the pointer to all those things, to all those other conditions or all those other entities that were found in this patient. That was when it was termed the syndrome X. So subsequently, the World Health Organization talked about, had a definition for it in 1998. And since then, a lot of other definitions have come up. In 1999, the European Group for the Study of Insulin Resistance, the EGIR, modified the WHO definition. And however, I'll still talk about the other definition. I'll talk about what these other definitions contained. Insulin resistance was still found to be a core component of this condition. But other things that were now noted were that the body mass index, the measure of body mass index was not included. However, the waist circumference, elevated waist circumference, was noted to be part of condition. So sorry. So in 2001, the National Cholesterol Education Adult Treatment Panel, that's the NCEP, the ATP3, had other definitions. But in this definition, insulin resistance was no longer part of the definition. Instead, the diagnosis consisted of included the fasting plasma, the waist circumference, hypertension, high triglycerides, and low HDL, which are the key components of metabolic syndrome. So other definitions are stated here, IDF and all that. So evolving definitions, WHO, following the other definitions and other things that came up, the WHO criteria emphasized the occurrence of insulin resistance with impaired fasting glucose, where the fasting glucose is about 100 to 125 milligram per DL, or an impaired glucose tolerance, that's the blood glucose level 2 hours after glucose loading with 75 grams glucose was between 140 to 199. That was the key core component of the WHO definition. However, for the national consensus of the ATP3 criteria, we talked about the combination of hyperglycemia, central obesity. I think I had already mentioned this earlier in the earlier definition for National Cholesterol Education Program. I mentioned that, so we'll move straight on now. So looking at this, the criteria for definition for the NCEP 83, we talked about having at least if you look at this, there are features, these other features, the elevated waist circumference, elevated triglyceride, high density lipids and cholesterol, blood pressure, and fasting blood glucose. For the ATP3, what it talked about was once any of these three features are present in an individual, and the individual has metabolic syndrome. That's a waist circumference of greater than 102 centimeters in men, or it's greater than or equal to 88 centimeters in women. Triglyceride greater than or equal to 1.7 millimoles per liter on treatment, and high density lipids and cholesterol. Talked about men having less than, that's good cholesterol. I talked about men having less than 1.03 millimoles per liter, women less than 1.29. The blood pressure, systolic greater than 130 millimeter mercury, and diastolic greater than or equal to 85 millimeter mercury, or hypertension treatment, or a patient that has or previously diagnosed with hypertension, and a fasting glucose greater than or equal to 5.6 millimoles per liter, or treatment for elevated blood glucose already. So these are the parameters for NCEP 83. However, for International Diabetes Federation, I talked about the waist circumference. The waist circumference are different for what you have in NCEP 83. For men is greater than 90 centimeters, women greater than 80 centimeters, along with any two of these other criteria I mentioned. That's the triglycerides, HDL, the blood pressure, the fasting blood glucose. So these are key things we really need to note about the criteria for definition of metabolic syndrome. So on to the risk factors. Yeah, I mentioned before that with increasing with the rising economic growth, people are getting older. The world is being a global space now. So a lot of things are going on, and because of this, the unhealthy lifestyles keep getting propagated and resulting in this. So I'll speak briefly about what the risk factors are, and we should pay attention to this because I think it will do us a lot of good. So the risk factors have been divided into two. We talk about the primary risk factors and the intermediate risk factors. Like the name entails, primary is something baseline, it comes up initially. Intermediate means something that comes up thereafter. So what we mean by the primary risk factors? They are the root or underlying attributes, or those things that are integral in that person, their behaviors, their lifestyle ways, or the things the individual gets exposed to. So they are primary things, like they are things indigenous to that person, like I mentioned, like your age, your race, like mentioned the black race earlier, your gender, women are more predisposed, your genetics, environment which you find yourself, both the physical and the social environment. They are social determinants of what risk factor you stand to what risk factor you stand to have in regarding this condition. Unhealthy lifestyle practices. I mentioned earlier unhealthy diets, fat and diets low in fruit and vegetables, diets high in fat, high in processed processed sugar, trans fats, rated fat, physical inactivity, tobacco use, alcohol abuse, even poor sleep. Sometimes you feel that, oh, I need to catch I don't need so much of sleep. I just need just a few minutes here and there. But I would like to tell us this morning that sleep has a whole lot of role to play in our metabolic health, even to our stress level controls also. These are the primary risk factors that have been found to be implicated in um, metabolic syndrome. So I'd just like to state this from evidence-based. Studies have found out that there's a positive correlation. Correlation means something that goes, once something is just like one goes after the other. Or if one increases, the other increases. If one decreases, the other decreases. So there's a positive correlation between physical inactivity and an increased prevalence of cardiometabolic morbidity and mortality. And another thing to also note about that, there was a study which we refer to as the Adventist Health Study, found out that there's been a linear relationship between a vegan dietary pattern versus a non-vegetarian dietary pattern, meaning that a vegan dietary pattern was found to be associated with lower body mass index and a lower of developing or coming down with metabolic syndrome. And coming back to sleep again, duration of sleep matters. Continuity of sleep matters. So this here states that this is a study that talks about the fact that short duration and disrupted sleep. So it's not even about the timing alone. It's the continuity of the sleep also matters. Due to variable sleep patterns, poor sleep behaviors, and other underlying sleep conditions they correlate with an elevated body mass index, obesity, metabolic syndrome, which we are talking about this morning, type 2 diabetes, cardiovascular risk, and mortality. So now we've gone down with the primary risk factors, coming down to the intermediate risk factors. So they are the factors that result from prolonged exposure or prolonged occurrence of that primary condition the individual has. So it's just like the patient keeps binging on unhealthy diets, keeps being physically inactive, keeps engaging in poor sleep behaviors, keeps being engaged in substance use. This for this period of time now results in these intermediate factors that stands also as a risk for coming down with metabolic syndrome. And these intermediate risk factors include being overweight or obese, and impaired glucose control, elevated blood pressure, high levels of insulin, and dyslipidemia. So I hope you can see this diagram. If you look closely here, using my cursor here, you can see this is where you have the risk. The risk is here, but if you look round at all, looking here, this shows what the primary risk factors are, the family history. The age is there, the race is there, the gender is there. Smoking is here, hypertension, overweight and obesity, what the role that the genetics plays also. We'll still come to this in like pathogenesis, in insulin resistance, how it alters the way the body stores glucose, how it alters the way the body breaks down glucose, eventually leading to abnormal glucose storage, leading to endothelial damage, leading to unnecessary lipid breakdown, which all now accumulates in this condition. So it's not just one, it's multifactorial. It comes to play in a lot of things. We look at the lipid metabolism here, talk about the bad cholesterol being high, the good ones being low. So, yeah, so now talk about the disease process. It's a complex process. It involves a lot of things into one. interplay of lifestyle factors, genes come in place, socioeconomic conditions, like I mentioned earlier, your housing conditions, your your feeding conditions, your food, the work you do, things you engage in, are major determinants that brings this to place, and all this comes together to result in one. But look, if you look at this last slide, it talks about the fact that said, however, for just all these things, actually, they are like a loaded gun. You place in a safety pouch. Talk about something that there's a common saying in lifestyle medicine that talks about the fact that it said genetics loads the gun, but lifestyle pulls the trigger. If you keep a gun loaded, it's going to be loaded forever. If you're going to keep it where it is, nobody touches it, you don't make room for necessary conditions for the trigger to be pulled. But once the trigger is pulled, loaded gun explodes. So now, you've talked about unhealthy practices, so we won't go over that again. So yes, disease process, what happens? How does it happen? The baseline factors that are responsible earlier, unhealthy lifestyle habits. We talk about the preclinical phase. That means the phase before which patients begins to see or begins to show features, or before which investigations are done, and you can outrightly see changes. So before then, other things are already happening in the background. And how do these things come to play? Consumption of unhealthy diets, or which also most likely would be accompanied by unhealthy lifestyle. There is a resultant overproduction of adipose, and this gets being deposited in the body, in the bloodstream, leading to excessive free fatty acid in the bloodstream. Eventually, because the body is trying to curtail this, it tries to increase the insulin level in such a way as to prevent this breakdown. It's coming in to help to curtail it. However, after a while, because the body cannot contain it for long, if the person keeps being exposed or keeps getting it, still has that particular condition still being there, eventually it leads to excessive insulin, because the insulin keeps being secreted, leading to a process called leading to a condition which we refer to as hyperinsulinemia, in which case this is now accompanied by excessive breakdown or increased level, because this insulin is higher. It stimulates this other the other lipid components, leading to increase the bad cholesterol and the good cholesterol. And this cycle keeps coming up. Eventually, the same hyperinsulinemia makes the person wants to eat more, wants to engage in those habits, leading to it's a cycle that keeps coming up and keeps coming up and keeps coming up. Eventually, it gets to a point the body can't handle any longer. And at this point, there is now these fatty acids that are now being deposited in the bloodstream now get deposited in areas where they should not be. Such areas like the coronary arteries, where we have in the heart, in the brain, and the likes. And thereafter, besides this deposition, it also comes along with what we refer to as we refer to them as pro-inflammatory markers. And what they do is what these pro-inflammatory markers do is to damage the blood vessels everywhere, both in the large organs, in the small organs, in the eyes, in the heart, in the kidneys. And eventually, this results in a high blood pressure. And when that happens, there's a resultant complication that comes up with it. Commonly, we have stroke, heart disease, kidney failure, and other conditions that come up. So I would want to skip this to avoid, to make it little clearer for us. If you look at this diagram, you can see the poor lifestyle choices at the tip, caloric excesses, inactivity, and all that, resulting to abdominal obesity, resultant, like what I explained earlier, dyslipidemia, hyperlipidemia, inflammation, hypercoagulability also comes in place. And now patient manifests increased waist circumference, increased triglycerides, the blood pressure is high, fasting blood sugar is high. Now the clinical outcomes now comes tips the patient to actual diabetes or arteriosclerotic conditions or complications now come in place. Yeah. So patient could present with hypertension, meaning the patient can come and show that, oh, hypertension could be what the patient comes down with. Hyperglycemia, high bad cholesterol, and increased fat around the abdomen. Sometimes they could also have something referred to as the acanthosis nigricans, which is a pointer to they are like dark spots on the body, in the extremities, and patient could come down with retinopathy, and all these pointers shows that the patient has this condition. Or commonly also, you could have the patient coming down with menstrual irregularities. Sometimes the patient comes here, as I've encountered patients coming with, the actual complaint is not even because they've noticed hyperglycemia or any of these conditions, but they actually found that they've been trying to achieve conception and it's not been possible. And when we try to take a history, carry out necessary investigation, we found out that this patient actually has this condition. And a lot of times when they're able to take measures, I've had a patient who had this particular condition and was able to take excessive measures and eventually was able to achieve conception. So aside these other things highlighted here, we also want to be sure that it's not everything that we mentioned here alone does not speak to metabolic syndrome alone. Other things you want to find that the person does not actually have is to find out that is there something we call secondary hypertension, maybe something that is actually causing that hypertension different from what we refer to as the primary hypertension that really doesn't have an explainable cause. Other things that are commonly, that could also occur, referred to as the renin and aldosterone metabolism, could also be inappropriate. Then family history of lipid disorders, thyroid disorders could also show could also show symptoms in this manner, as well as the other listed conditions I mentioned here. So basic things would want to assess the patient after taking your necessary, asking about history, the family history, social history, the living condition of the patient, the work condition, the socioeconomic determinants of those patients, to find out what other things that are making the patient prone to this particular condition. Then you could request, all these investigations could be requested for. Check for the lipid level, the glucose level, renal function, the thyroid function, and other things that are related would also be necessary to find out in this patient, which have been stated in this slide. And depending on what the patient presents with, also, you may want to also investigate in that direction. So not only restricting yourself in that light. So importantly, I want to talk about something referred to as indices. Those are the measures or things we measure in this set of patients to help us to come to make a diagnosis of this condition, either to make a diagnosis or to see, oh, does this patient stand a high risk or this patient stand a low risk? If you check different levels of a parameter and one is higher than the other, obviously you know that, oh, this person definitely stands a higher risk than this other person. So the way you want to intervene for that person may not actually be the same. In the same light also, we also want to use them over time to monitor these patients. Find out, oh, what I'm doing, is it actually effective? Is the patient actually benefiting from it? Are we making a headway? That's the reason. Those are the importance of checking out these indices. And what are they? Talk about the body mass index, which is the measure of the person's weight to the height of the person. That is easily done. It's easily accessible. Get a scale and check the height of the patient, and you compare each other. We talk about the waist circumference. That's the measurement at the waistline. It helps to assess for abdominal obesity. Then talk about the waist-hip ratio, the waist-height ratio. Commonly, we do the waist circumference, body mass index, a whole lot. The lipid indices I also mentioned earlier. There's something we call the bad cholesterol, the good cholesterol, triglycerides. So in these patients, a lot of times they have this good cholesterol that helps in the body being low, and the bad ones are on the higher level. And you may want to compare what these lipid levels are with the glucose levels. Blood pressure is also very important. Monitoring the blood pressure of the patient, the systolic, the one on top and the one beneath. Fasting blood sugar, overnight fasting blood sugar. Then other things referred to as the metabolic syndrome index, the waist circumference index, and the likes. I want to skip this also. Yeah, so, and for us, it's something we can easily even do for ourselves, because there are apps which refer to as there's something referred to as the IDF metabolic syndrome calculator. So what you can just do is it's a medical app created by this QXMG. When you're able to download it, it asks specific questions talking about, does the patient have, following the body mass index, if you have a body mass index greater than this, is able to ask you, you're able to impute it into it, your gender, what level are you. So if you have your results, your lipid levels, your blood pressure levels, your fasting blood sugar, you can input it into this calculator, and eventually you will be able to find out, do I actually stand the risk of this condition or I don't. So it's also something you can easily do by ourselves. So when you do that, you can now seek, or you can actually, you can seek help. You can seek help, clinical help, and it's not something you're going to manage all by yourself. So this is just like it's an home-based device or home-based activity you can actually do to see the risk you stand. So this calculator is based on the International Diabetes Federation worldwide definition for metabolic syndrome. So for the diagnosis of metabolic syndrome, it requires that person has a body mass index that is greater than 30 kilogram per meter square. That's the weight compared to the height. Waist circumference, yes, I need to mention that also. For certain set of people or certain nationalities like the Asians, they found out that even for them at a lower waist circumference, they have a higher body fat. So for theirs, their own waist circumference measures are usually lower than what we have stated for this. So under the other criteria, you have the waist circumference being greater than, that's measuring around the waist region with the tape measure, greater than 102 centimeters for men, or greater than 88 centimeters for women. Triglycerides, depending on what measure it comes, whether it's in milligram per DL, it's being converted to the millimoles per liter, greater than 150. For the HDL, the high density lipoprotein, that's less than 40 for men, in milligrams per deciliter, and for women, greater than 50 milligrams per deciliter. A blood pressure greater than or equal to 130/85, and a fasting blood glucose greater than 110 milligrams per ml. So any of these, once the individual has any of these three, so it doesn't have to be all the five. Once any of these three are present, or this ATP, NCAP 83 criteria, then the patient fulfills the criteria for metabolic syndrome. So now I want to talk about intervention here. So that's really key. It's critical for us also to note that the approach to intervening for this condition is a multidisciplinary approach. It's not just a one-pronged approach. Go round, you're able to, it's not just for the individual, for the government, for the patient, for the families. What role each of these people have to play is really important. And because this condition, like I mentioned earlier, that even when it has started, the patient doesn't even, when you pick up the patient, you may not even see anything in the first place. But this issue, this condition is already in the offering, but it's not yet stated as well. We can, at that point, it's easy to catch up it may not be easy to catch up the patient. However, routine or regular engagement like we are doing right now, this enlightenment that is being done, be able to make the patient take proactive measures, proactive steps in being able to curtail all of this in terms of the conditions that may predispose the patient to coming down with it. So first step I would say is awareness, raising awareness, yes, which we are doing right now, educating the general populace about what this is. And then taking actual measures, taking actual steps or intervention policies and programs that may help to curtail this condition before it eventually or actually develops. So what are those things? We are carrying out this webinar this morning. We have been enlightened. We can pass this on. A lot of people will get to know about it and learn more and know how to intervene on their own side also. Talk about instituting a workplace health promotion program. Yes, so even at the workplaces where we are or where we work, a lot of time we stand a risk of coming down with certain conditions. However, within implementation of these workplace health promotion programs, most of these things are able to be picked up. Other things that would also come to play include a provision of recreational and social facilities that could help to improve physical activity, creating a very good easily walkable or walkway while carrying out construction. Sometimes you find out people will tell you, oh, I cannot exercise because sometimes I don't want to leave my house. Sometimes I really would have loved to leave my house, but my area is I cannot walk around this area, or I don't feel safe around where I live. I have these issues and all that. But if all these things are tackled, then this would also indirectly have effect on this. Enforcement of policies, especially on substance use, increasing taxation on calorie-dense meals, on alcohols, those food contents that tend to increase the risk of individuals coming up with this. Then introducing tax incentives for people who are engaged in fruits. We all know that fruits and vegetables, they're higher in nutrients. They are not as calorie dense as you have in other processed meals or other fatty meals or other meals that are not as healthy as that. So if there's a tax reduction, it may help to engage and increase, and it may help to make people show a lot of interest in these areas. And in so doing, people are able to pick up most of these items, and eventually, now we're even talking about farming or gardening by yourselves. Because sometimes this could also help to, or sometimes you say, okay, I don't want to get a lot of all these GMO products. Then it may also encourage you to start a little garden. You may not need a whole large expanse of land. You can even start with the seedlings using your cups and all that. Eventually, you're able to come up with all these things. So it may look little, but they have a whole lot of roles to play. Health-friendly restaurants. Yes, I'm aware that there are some restaurants that actually don't serve the menu is actually their healthy menus. They have some things that have been taken out of the meals that are not, they refer to as not health-friendly or pose a risk of individuals coming down with the condition. So a lot of times, it's better if we have to, maybe to patronize this restaurant and reduce our risk of this condition. So when would you talk about, yes, aside that, we talk about clinical intervention. So in what ways would you, what would you refer to as clinical intervention? Now you're talking about trying to reduce your base, if a patient comes in with being overweight or obese or the higher levels of classes of obesity, then interventions are put in place in terms of maybe starting on lipid lowering agents and other things, inclusive of the health or the lifestyle measures together with this to help to reduce these indices, apart from the weight itself, to help to reduce the indices we talked about earlier, the LDL, the triglycerides, help to increase this, the reduce blood pressure, hyperinsulinemia, insulin resistance, and all that. Yes, I made this highlighter because in these interventions can also be done even if the individual does not have overt diabetes or overt high blood pressure, but you can see that this is really coming up. You don't want to wait until the individual begins to has actually developed that you can begin to institute those measures. It's been said that the best time to plant a tree is now. Best time to plant a tree, sorry, was yesterday, but the next best time is now. So where you meet it, you can start off from there. So, and most of these things help to intervene regarding the cardiometabolic risk factors and eventually reducing the modifiable, the primary risk conditions. So studies have also found out that a significant number of middle and older age adults who engage in regular physical activity, they experience a reduction in some of these conditions, or even those who even have those conditions: hypertension, improved body mass index, truncal obesity reducing, improved glucose tolerance, improved lipid levels, and some of these inflammatory markers are also being reduced. And it's also good to know that these measures will be instituted for a both short and over a long period of time. So for these measures, usually indicated when you see that the lifestyle education only will not be effective in intervening for this patient, or when you see that the values when you score or you do those risk scores and you find out that those individuals have a higher risk, then you don't want to just stick to saying, oh, do those lifestyle measures. You can introduce other adjuncts at those times, yes, like your lipid lowering drugs, anticoagulant, psychotherapy. We talk about bariatric surgery. Would also be other forms of adjunct therapies. Okay, so I just want to talk about this briefly. Talks about the fact that using lifestyle pillars. Yes, in lifestyle medicine, we refer to some things as pillars. They are the major things that are being focused on, which includes a healthy diet, regular physical activity, stress reduction, and avoidance of toxic substances. Then you have your you're having interconnectedness, and I think I'm not sure I missed any. I think the sleep, yes. I think that's the sixth one. So in this area now, we talk about the treatment of diseases with these lifestyle pillars. There are some evidence-based studies which were noted, and the results showed what role lifestyle measures play in managing this condition, these chronic conditions over a period of time. Talk about the Lifestyle Heart Trial, which was a 5-year randomized control trial. Talk about the Popular Diabetes Prevention Program, we talk about the reduction of the incidence of type 2 diabetes with lifestyle intervention or metformin. The participants were divided into both intervention. They were divided into they were placed on both some were placed on medication, some were placed on life, but I won't be speaking so much on this. Then the portfolio diets, the cholesterol lowering drugs, lowering food versus the lipids lowering drugs, which was also done over a 3-month period. It was also a randomized control trial. But the one that speaks to metabolic syndrome here is the therapeutic lifestyle change intervention. We talk about the intervention using the drugs for hypertension, that's amlodipine and atorvastatin. For participants in this study, it was a randomized control trial. So patients were randomized. Some were placed on therapeutic lifestyle change plus placebo, while some were placed on therapeutic lifestyle change plus this medication, that's amlodipine and atorvastatin, over a 12-month period. And what was the objective of this study was to examine whether the addition of this combination of amlodipine and atorvastatin. Amlodipine is a drug for hypertension. Atorvastatin is a drug for lowering cholesterol. To find out if implementing this would benefit or have a way of modulating or improving metabolic syndrome. That was the essence of this therapeutic lifestyle change intervention study. So what was the conclusion of this study? It was found out that the addition of this combination drug has the advantage of improving the lipid profile and the blood pressure, but also therapeutic lifestyle change was comparable with adding the lifestyle change together with amlodipine and atorvastatin, meaning that an intensive form of this therapeutic change was comparable with combining this with the medication. Another things to be noted were improved weight, and the metabolic indices were also noted to improve in these patients. So as I round up now, so I'll summarize by saying cardiovascular disease and type 2 diabetes, like I mentioned earlier, they have an interconnectedness, they have a connection together. They have a similar pathophysiology. So in an attempt to treat any of this, it's important to consider the fact that it may not just be that individual condition, meaning hypertension or diabetes alone the patient has, but also find that this patient has this cardiometabolic syndrome. There's a need for us to pay due attention to consider if there's a possibility of this in this set of patients, because this will help us in improving care and in getting better results over a long time. And then, how do we do this? Beyond what we do, beyond all we have always done, there's a need to improve or institute health promoting measures that pays a whole lot of attention in prevention, assessment, and treatment of these modifiable risk factors, which have been mentioned earlier, such a way that these conditions could be curtailed even before it gets to the chronic stage. So it's about the same here. It's there's a need for interdisciplinary approach incorporating lifestyle measures and pharmacological therapies when indicated. And we should also remember this is not just an adult condition. It's important to note that children and adolescents also stand a risk. So I'll end my presentation with this slide that says, "Be the change you wish to see in the world." We've talked a whole lot here today. We want things to change, but the change starts with you. Change starts with me. Change starts with you. Thank you for listening. And these are my references.
Wow, thank you so much for your presentation, Ma. It was so insightful. Thank you very much for explaining to us so many things. We have learned today about what metabolic syndrome is. We talked about the different names that it's also called. We have talked about the components of metabolic syndrome generally, and the things that we need to do to improve these conditions. I took quite a number of things down, and I hope that we have all learned one or two things. But before we take the questions, I just want to emphasize that she mentioned that there's a need for lifestyle modifications. There are so many lifestyle modifications that we need to carry out. And she said it's not only when you have been diagnosed that we should start. So it's something we should start incorporating into our lifestyle from now. She talked about sleep. She talked about diet. She talked about physical activity. She also mentioned planting gardens. And she said it doesn't have to be in a space of land. Sometimes we can use little cups to plant. These have all been taken down and have been so helpful to us. I hope everyone here had one or two things that they learned from this presentation. Thank you so much, Ma, for your expert opinion and your presentation. It was very enlightening. So now we have questions. Question time. If you have questions, please raise your electronic hands or type it in the chat box. I will read the questions. Yes. Thank you very much. Someone has typed here, well appreciated. Information. the change starts with me. Many things. Very, very important. The change starts with me. When I'm able to incorporate this lifestyle modification, can tell all about it. And they can, and we can just please raise your electronic hands or type in your questions in the chat box. We have a few minutes to take the questions. Okay. So while we wait for other questions to come up, my own question is about waist circumference. You talked about waist circumference. Where exactly do we put our tape to measure, and what are the numbers that we want to get when measuring the waist circumference, such that everybody here can apply that, seeing that maybe just in case you don't have a machine for checking blood pressure, or we can't check our blood sugar at home today, we can take a tape measure and measure our waist and know where we stand, ma. So could you kindly shed some light on that, so that everybody can take that as a take-home message, and we can try that to know how healthy we are today. Thank you, ma.
Okay. Thank you once again, Dr. Jalabi. I wanted to go back to this slide. Okay, yes. So for the waist circumference, what you do is you get the regular tape measure, the ones the tailors use, and you from the lowermost part, the topmost part of your after your ribs, immediately after your ribs, down before you feel the hip bones. A midpoint, usually at the level of your umbilical, that's your belly button, that's umbilicus. At that point, that is where you measure from. You put the tape round about that, and you are sure that the tape measure is not folded, is not lying on each other. It's smooth enough for you, and by the time it's not too tight also. And by the time you do that, you're able to get an appropriate measure for yourself.
All right, ma. Thank you very much. And from the slide, it also says that 102 centimeters in men.
Yes, men, yes, and greater than 88 for women.
For women. So we should all go and measure our waist circumferences so that we can know how healthy we are. Thank you. Madam Dorothy, please, you have the floor.
Yeah, good morning. This is
Madam
Dorothy.
Dorothy, okay. Okay,
Yeah.
please go ahead, ma'am.
Thank you very much, ma'am. I have a question, please, regarding this herbal remedies that is online. I mean, you have loads and loads of them. They tell you if you take this, your BP will go down. It works for diabetes, is whatever. So what do you think? Should we ditch the normal conventional chemicals and go for the herbals, or just give me an idea, please? Thank you very much.
All right, thank you very much for that question. So she's asking if she should ditch the chemicals and go for herbal. What is your take on herbal remedies for all of these cardiovascular diseases? Oh, okay. Go ahead, ma.
Okay, sorry, I had to join with my phone. All right. So I didn't hear the question.
Okay, ma. She was asking about herbal remedies. She asked if what your take really is on herbal remedies. Should she continue taking chemical substances such as medications? I believe. I hope I'm getting the question right. Or should she go for herbal remedies? There are so many of them that they talk about online. So she's asking for your own take on herbal remedy. Madam Dorothy, did I get you correctly?
Yes, please.
Oh,
Thank you.
Thank you, Madam Dorothy. Thanks for the question. Yeah. So My take on this will be from a physician point of view. So I would say that you have the orthodox medicine, you have those herbal medicines, but you are sure that for your orthodox medicine, you know the dosage, you know the constituent, you know what it does, you know that it's not bobo niche, it's not doing curing hypertension, curing diabetes, curing all manner of things in one. You know that you know the appropriate dosage that will not be toxic to your kidneys, that will not be toxic to your liver and all that. So I would say that for that reason, orthodox medicine stands a better chance for you. If you are going to, then apart from that, a lot of these herbal medications have a lot of interactions with the orthodox medicine. And if you continually or consistently engage in using these together, maybe you're using the herbal products, you're using that, then you could have some form of drug-drug interactions, or sometimes some form of, unless some eventual results that you really don't want to handle. So I would say stick to your orthodox medicine. You know what it does, you know what it's doing, you know the effects, you know what comes up from it. So that'll be my take on that. I hope I answered your question, please.
Yeah, that's all right. Thank you very much.
You're welcome, ma'am.
Thank you very much, ma'am. Thank you for that question and thank you for the response, ma'am. There are some questions from YouTube. So let me read one out. So from Mrs. Adeyemi Deborah, she says, my weight is 57 kilograms. Now my blood pressure has been well regulated. But I notice that when I want to use toilet, my BP goes up. What could have been the cause? And she says she's 76 years old. So she says when she wants to use the toilet, her BP goes up. She didn't specify how high, but she's wondering what could be the cause of her BP going up when she wants to use the toilet or the restroom.
Okay, thank you for the question also. So I'll address that by saying that I'll start off with saying that when you want to measure blood pressure, there are certain conditions that you should ensure, because a lot of times certain things interfere with the blood pressure measure we get. We get different blood pressure measurements at different times and at different positions, at different circumstances. So one of the things you want to put in place that we talk about is when you want to measure your blood pressure, ensure that you are not pressed. That's not the time, because there's a tendency that you are likely going to have a falsely high reading, especially when you want to use the toilet like you mentioned, or when you are pressed, or when you are seated uncomfortably, or your legs are crossed, or you just drank certain, maybe a caffeine containing drink or something that would likely raise your blood pressure, or you are not, or the way you're even applying the cuff, or the size of the cuff. So it talks about the patient conditions, the apparatus conditions, and the environment also matters a lot. So it's important that anytime we want to take our blood pressure, let's be sure we ensure optimal conditions. It's not the time when you're feeling sweaty, when you're hot, when you're just walking from a long distance, you now sit down. That may not be the appropriate time to take the blood pressure. You need to settle in. Maybe wait for about 5 minutes. You are well seated, your back is well rested, your feet are on the floor, your arms are on your chair, your apparatus is at the level of your heart. You are not pressed. It's not the time you want to pee, or it's not the time you're coughing, or you're suddenly coughing repeatedly. That may not be a good time. So for you, it may be because of the timing of that period of wanting to use the toilet. So I would rather say that you should take your measures when you are well rested, when all of these conditions I mentioned are not there. Thank you.
Thank you so much, ma. So when to take your blood pressure is important so that you can get the appropriate reading. It's not uncommon to have elevated blood pressure before or when you are feeling pressed to use the toilet. The point is noted, ma. Thank you very much, ma. Mrs. Adepoju, please go ahead with your question or comment. You can unmute yourself, Mrs. Adepoju, and ask a question
To also
or make it.
react to, yes, to Mrs. Dorothy's. Thank you, Dr. Eniola, for a beautiful presentation. My own takeaway from your presentation is the part that says that, I may not be quoting it verbatim, that says that genetics is the, hey, God help me,
Okay,
is
can I help you out
the,
on that? Can I help you
please
out?
help me. Yes,
So
yes, yes,
I'll say
please help.
that
But let me know,
I said
but let me say it the way I understand it before you help me, so that you know
okay,
I got
all
it.
right,
So
it's
that you
okay.
that genetics, is the gun itself or something, but lifestyle is the trigger. I don't know if I said it right, but what I
All
get
right.
from that is you may have, and one thing that kept ringing in my mind as you're saying that thing is my case can be different. So that they say that there is a hypertension running in my family does not mean I must come down with hypertension, except I help hypertension to manifest in my life. Am I correct, ma'am?
Very correct. I'll say that you're correct. So can I
Uh-huh.
can I
So
help can I
life,
help you to rephrase that statement again,
yes,
if you don't
please go
mind?
ahead. Yes, please go ahead,
So
ma'am.
what that statement is that genetics loads the gun, but lifestyle pulls the trigger.
Uh-huh.
So it's
Genetic
just
loads
yeah,
the
loads the gun.
gun,
Yeah, just like having a
lifestyle.
loaded a cocked gun. If
Yeah,
you leave it there, nothing happens to it. But once you pull the
yeah,
trigger, then
yeah,
it fires up. So
yeah,
I'm happy
yeah.
you're able to
Thank
get
you.
that take from here.
That one, no, that one, and
Mm.
I'll keep passing it on because I'm an
All
advocate
right.
of prevention.
Um,
But you see, I'm often careful to talk at meetings like this, and Dr. Bushi will tell you that I keep encouraging my people to join your meetings because I know that when people are enlightened, just like the Bible says that people perish for lack of knowledge. When they are enlightened, they will know how to avoid many of these things. What are what they are doing that is wrong? So I appreciate this kind of meeting. However, I want to share a personal experience, to kind of react to what Mrs. Dorothy asked, the question about herbals or no herbals. So for me, what I would say to her is find what works for you. Sincerely Orthodox medicine is awesome, it's amazing, but I have had a few negative experience, whereby people who are close to me, especially on this hypertension thing, I have a woman who passed on, It's that for me, it is a side effect of many Orthodox medicines, much as the herbals also have, their downsides. But it is that when I find the one, that is being put out by a reliable company, a company that I know has even doctors on their, board or manufacturing, whatever, who do this measurement thing, the dosage and all of those. For me, I do herbals because herbs, fruits, veggies, and all of those, they're a gift from God to us, and they work very well for me. I've been under the knife for fibroid before, and because of that, I had my two children via cesarean section because it was an extensive surgery because it was multiple uterine myoma. However, when the fibroid regrew, the natural thing my doctors told me was to go under the knife again, you know, and this is after having gone 3 times. But thankfully, I found one of these so-called, therapies, and it worked for me. So for me, there is nothing you can say to convince me not to do herbals. But my own is I will do it in a balanced way. I have people that have, used it to help to burn bad fats and what have you. So do it in a balanced way. If orthodox medicine works for you, go for it. If it's giving you negative side, I've seen people with diverse negative side effects from BP drugs and what have you. While it works for some. So for me, both are just fine. Both, as long as there's no drug interaction, you can space out your usage, your time of usage or intake, and you're fine. Then be good. Be good. I mean, because it's better to do safe herbals, safe orthodox, than just die untimely or prematurely. But above all, that lifestyle change or modification helps a whole lot. I can attest to that. And I can attest to the fact that stress, God, everybody, please listen to your body. Stress, number one killer. Stress, please listen to your body. If your body is saying it cannot take it anymore, just pause. Nothing is an emergency. You can wait till tomorrow. If you think it can't wait, when you pass on, God forbid, you will know that everything in this life can wait. Thank you so much. God bless you all.
Thank you so much for your comments, Mrs. Adepoju. Thank you so much. Thank you. Does the presenter have any responses to that, or
Okay. Yeah, I think I do. Thank you
okay?
once again, Ms. Adepoju, for sharing your insights. I really appreciate it because a lot of times true life experiences or scenarios helps us to better understand certain things and helps us to take decisive steps. So I'm not I won't be I don't doubt your beliefs. I don't doubt that, oh, this is your take on that, yeah. But I would also say that it's important to note that some of these herbal products have some orthodox medicine that have been actually added in disguise to them. That's one thing we should note. That's one. Then secondly, yes, you talk about the interactions, you talk about some being safe, but how safe can your safe be safe? If I pick up a tablet of a particular medication right now, I can see the experience. I can see, oh, this is what this contains. It tells me these are the likely side effects I may get from this. These are the reactions I may get from this. So when that is done, there may be a need to. That's why sometimes a lot of our patients on these medications, we do routine investigations to follow up. Or do we need to change from this class of drug? Do I need to replace with this? So sometimes it may not just be just that particular medication. If there's a need to change for one that is less toxic or that will be more effective with less interactions, then we do same. However, um, there's something we call the complementary and alternative medicine. Complementary means that you are adding something that helps, that's potentiating what you're using. When you talk about talking about your ginger, your garlic, your all that, a lot of times that may not be strictly herbal in code because you are, they are more like natural products. However, some of these herbal products have more things than what you see, even in what the content contains sometimes. So, well, I would say that we should just still put in a lot of caution when it comes to this. As much as we want this, I would encourage that we put in so much caution, seek information, seek clarification, try to understand more, and hopefully we're able to make the right decisions at the end of the day. Thank you.
Thank you so much. Thank you so much, ma. Thank you so much, ma. Okay, so in the absence of any other questions, I think I'll leave the floor for Dr. Busui to give his vote of thanks and to round up the meeting.
Thank you very much. Good morning. Good morning, all. Thank you very much for joining. And before I give the vote of thanks, I just want our speaker to also help us throw light about when we talk about diet. I think the timing when we eat also matters. I want to help me to speak to this. What's your take about breakfast? When is the ideal?
Okay.
Because some people will say I'm dieting, I don't eat in the morning, I eat in the evening, I eat around this, I eat around that. I just want to throw light about
Okay.
when should we
All
eat,
right.
how should we arrange our meal in a way to be able to help us to get a good balance, in a way to, like someone that want to lose weight, how should we arrange the meal pattern? And then even someone that don't want to lose weight, how do we just arrange the meal pattern in a way that will make us have a healthy lifestyle? Thank you very much.
All right. Thank you, sir, for that question and wanting me to share more light on that. So, yes, diets, the type of diets, the timing, then even the amount of the diet also matters. So, we talk about the fact that the timing of your diet for in a 24-hour period. A lot of times, some of us will have heard of intermittent fasting, this and all that. The most important thing in all of this is that you are not depleting yourself of the necessary nutrients. That's really important. And how do you do that? The way you do that is not by skipping your meals. So breakfast still is very important. The most important thing here is that I'm sure that a lot of adults in our environment, most people, if you ask about 5 people, I'm sure most people say, okay, I take my breakfast. Sometimes I skip, lunch. Sometimes I take my dinner. Sometimes some would even tell you I take dinner alone. I say, "Oh, I'm fast. I'm trying to lose weight, so I just take 1 meal a day." But I'll tell you, that kind of a person takes 1 meal a day, but takes that meal at after working all through the day, takes that meal at about between 8 p.m. to 9 p.m. Downs down a big bowl of swallow with a lot of proteins in it, with a lot of oily foods and all that. I say, okay, it's just that meal I'm taking. But you have forgotten that that single meal you have taken, if you want to calculate the calories alone, all the periods you felt you had fasted, you are now trying to load up yourself with excess calories. So the take is all your meals are important. Your breakfast before noon, your lunch, just about midday or thereafter. Then if you can, a lot of times, okay, if you skip that, if you want to, you can do that. But if you are going to snack, possibly in the afternoons or for your lunch, you take something healthy. You are snacking doesn't mean, oh, I am going to now start eating a lot of biscuits, a lot of chocolate. That may also, it may look like a bar of chocolate. When you compare what you have in a bar of chocolate to what you have in one whole fruit like an apple, they are two different things. One looks smaller, but you have more unhealthy calories and no nutrients in that. Whereas in the other one, you have healthy nutrients. So the key to balance, I would say, is that your portion control is very important. That's one. Your meal time, your breakfast is important. Your lunch is important. If you can't afford it, your dinner is also important. However, if you are the type that takes your breakfast and takes lunch and takes dinner, as much as you can between each meals, at least you may need to give at least before the food gets easily digested, you may need to take as much as between 3 hours to 4 hours. So that means that I cannot be taking an heavy lunch at about 3 p.m. and by 6 p.m. I'm already taking another meal. That may not entirely be appropriate. Or it may not be appropriate for me to say, okay, I'm taking my dinner by 8 p.m. and I'm going to bed by 10 p.m. The food hasn't even digested, it has not even spaced out a lot. So we say that you give an allowance of time, especially because one of the risk factors for abdominal obesity is late night meals. So sometimes people say, I don't eat at all, I don't take my breakfast, I'm trying to lose it, but the only meal they take is that nice meal. And the timing between the meal time and the bedtime is just maybe roughly about 1 hour, 2 hours. So we say at least you need as much as between 3 to 4 hours. So that means that if I'm going to be taking my dinner at about 6 p.m., if I'm going to be sleep, if my bedtime is about 10 p.m., that means by 7, I should have been done with my dinner, because at least that gives me an allowance about 3 hours before then. But I cannot be taking it at 8 and expect that my body will not, I won't be storing excess, I won't be storing calories or storing abdominal fat or having all that. So portion control, spacing of the time between meals. Then while eating the meal, what the food contains, what portions, we talk about each of your meal, we talk about you having at least 5 servings of fruits and vegetables in a day. So what that means is that a serving is like a whole portion of a fruit, maybe like an apple or a slice of watermelon or a slice of or one finger of banana and all that. So that means that aside my vegetables, so that means that if I'm taking my lunch, my breakfast in the morning, and I'm taking possibly a slice of yam with garden egg, not the ones soaked in palm oil or oily food, or I've put a lot of anywhere and all that in that. I'm taking that I'm taking that early enough, possibly say around between my 9-10, if I am able to. By afternoon, possibly around say 2-3, I'm ready to take, maybe if I'm going to snack on something, possibly maybe snack on or take a bite of watermelon or take a banana, but I'm not snacking on cake. I'm not eating biscuits. I'm not engaging in chocolate and all that. And by dinner, I'm taking a light dinner. Possibly I'm taking amala with ewedu with my fish. Even though I've eaten all through the day, I'm going to lose weight compared to somebody who now who takes maybe while at work, takes biscuits, take a whole wrap of biscuits in the afternoon, and now comes home at night and now eats say possibly, let's say, eba with a lot of egusi soup with maybe 5 pieces of meat Oh, I'm boiling yam with a lot. Maybe I'm boiling like 5 eggs or boiling 3 eggs. We are both eating, but our portions are different. Our timings are different. What our meals contains are different. So those are the key things I want us to pick: the timing, the portion of the meal, and what is the consistency and how healthy. When you are looking at your plate, you say, eat a rainbow every day. When you look at your plate, half of your plate, each at every point in time, should be vegetable based. Could be your regular green vegetables, could be it could be your cabbage you slice, your carrots, but at every point, when you look at that plate, half of it should be vegetable based. So that means if I'm eating rice now, a portion or maybe a quarter portion of my plate is the white rice. I'm having possibly beans, maybe I'm having some pieces of vegetables. So in all, I'm not eating too much, but I'm still balancing it. There's a difference between that healthy diet and balanced diet. They're two different things. So it's healthy for me. I'm not exceeding my portion control, and I'm not overeating in bounds like that. So I hope I've been able to answer that question.
Thank you very much, man. You've answered
Thank
it.
you.
Well, I also, so to wrap it up, I want to appreciate you, man, for choosing to do this pro bono service to the community, to the society. And
You're
good
most
thing is that
welcome.
is currently live on YouTube. People can always go there to watch and then learn from it. And if right, they can give feedback questions. And also, I want to appreciate everyone that was able to join out of their busy schedule today. And I want to appreciate you for this and also inform us that this is a monthly thing that we always come up. We always see the notification about our meetings. The essence of it, this meeting is born out of need to just educate community about hypertension and what to do about it, how to do about it, because in the community, a lot of things goes on when people don't know what to do. People, even I had last month I saw a woman that told me that the BP is there, he's not ready to treat it, he's not ready to use anything. If you want to die, you just die. Or people to tell you that BP is there, there's nothing I can do. So a lot of things goes on in the community with this hypertension. And also another thing I also noticed is that even though there's a society of doctors who have for hypertension, there is still no like we have people living with diabetes and other conditions. There's really no prayer group yet pushing for things to be done in the area of hypertension to be able to help the community, because especially now that we have a lot of economy downturn, a lot of people are not even able to afford the basic BP medications, and we know what this means. So the essence of this is to keep educating the community, and I want to appreciate you for obliging us your time and effort in preparing these slides and be able to make it available for us and give us this education. Thank you very much. And lastly, I want to ask on behalf of others that may want to look through the slide later on to please help me forward this slide so that I can make it available for them. So thank you all. Thank you very much for this meeting. And then I also appreciate us for being able to come at this seemingly other hours too, because I just felt today is holiday. Let's do early in the morning or like the night. So thank you very much. God bless us all. So I
Thank you.
will, yes, I will. Thank you very much. Our moderator, Dr. Ajelavi, thank you very much for
Thank you,
choosing.
Bye,
Dr.
everyone.
Lucy,
Bye.
for this.
We
Bye.
appreciate you too. Thank you. So I will end the meeting.